to today's live chat with our very own Dr. Andre Dixon. Dr. Dixon is a board certified internist, and he's also the son of Sister Louise Dixon, who has been with our church family since the beginning. So we're so grateful for Dr. Dixon for agreeing to do this with us today. So he's just basically going to share some information with us and answer some of our questions. So if you have a question as we go along, you can either put it in the chat or you can raise your hand. Preferably put it in the chat, and then we'll try to make sure we ask the question and Dr. Dixon will answer it. So before we get started with our questions, I'd like to let Dr. Dixon introduce himself and also share some helpful information regarding a topic that's on everyone's mind, and that's COVID-19. So, Dr. Dixon, with no further ado, we'll turn it over to you.
Thank you so much, Ms. Dawn. So as Ms. Dawn stated, I am a board certified internist, meaning that I've trained in internal medicine, which in short is general adult medicine. So I think we're all adults here in this room, so feel free to ask any questions related to adult healthcare. Although we kind of started this planning based on kind of a COVID discussion, but feel free to ask any questions that I'll do my best to answer. I think as far as COVID goes, we're still trying to figure out a lot of information about it. I remember when this sort of first came out to the United States in late February, early March, and the rumor was that African Americans couldn't get it. And then about a month later, we're finding out that it's actually affecting African Americans even more devastatingly than other races. And so maybe we can get into some of the reasons why that might be, or things that we as a church can maybe do to kind of help for patients that are, or people that are more susceptible to healthcare disparities in general.
Mm-hmm. Okay, thank you. So our first question is, please explain how it spreads, and also if you can break down this curve we keep hearing about.
Sure. So all evidence that we have states that this virus is spread from droplets. It's not quite airborne, more so droplets. So it's believed to be spread from person to person contact, either from a cough and droplet spread, a sneeze, even any forceful air from the diaphragm puts these droplets into the air. And if no one's within distance of these droplets, then there's no way for it to transmit from person to person. However, if we're kind of in tight spaces, whether it's schools, restaurants, and people are coughing, not covering their mouth, or even touching surfaces and then touching their eyes, nose, or mouth, that's how the virus is spread. As far as the curve that we're hearing about, because this disease is so new to us and affecting people in such a devastating way, our healthcare system was very overwhelmed at the very beginning onset of the pandemic with a lot of respiratory illnesses. And so the spreading of the curve is us doing our part to social distance to limit the rate of transmission, so that the hospitals are not running out of respirators, running out of staff to be able to take care of people, kind of making sure that we limit the rate of infection so that the people who do get sick are adequately cared for.
Okay, thank you. So you alluded to this earlier, but why do you think it affects African Americans more than anyone else? I've heard about, limited access to care and things like that, but some people kind of think it's just some sort of biological defect that we have or whatever? And what about other minority groups? Why do they just kind of keep saying African Americans are suffering the most? Why do you think that is?
I think historically, African Americans in America in general, we tend to have a very sort of distrust for the healthcare system. And as a result, I think a lot of us don't like going to the doctor. We think as long as we feel fine, that we are fine. Although there are many guidelines that state that we have certain things that we need to do by certain ages, whether you're age 50 and getting a colonoscopy, or making sure you get adequate pap smears beginning at age 21, at least every 3 years. All these are things that we should all be doing just to kind of prevent future healthcare disparities. But I think we as a people, rightfully so, because there have been some shady things done to African Americans regarding the healthcare system, Tuskegee experiments and so on and so forth. I think we do have a distrust for the healthcare system. And as a result, I think we have a lot of healthcare disparities that go undiagnosed. A lot of us in here could have high blood pressure and not even know it if we don't actually have a blood pressure cuff at home or visit our doctors to get our blood pressure checks. We could have diabetes and not know if we don't have symptoms that prompt us to see a doctor. And so I think we tend to have these disorders in higher discrepancies than other races. And once we get sick with something like COVID or the flu, the damage that had been done by prior diseases like diabetes and hypertension tends to kind of, it's more detrimental when people have these other health conditions that haven't been treated or cared for.
Okay, well, that certainly makes sense to me. I don't know whether anybody has any questions. But if not, then I will keep going on the list of questions that I got prior to our meeting. So what about the symptoms? I want to talk about that for a second. Before we were hearing the ones to look out for, and I guess it's still true, is the high fever, the dry cough, and the shortness of breath. But now there's a lot swirling around the internet again about African Americans, which we all are in this room, about how we often don't present with the same symptoms like that. You know, the fever, the coughing, the shortness of breath. You know, they're saying a lot of times we don't even have symptoms, or we may have symptoms like loss of taste or smell. I'm starting to hear maybe more of that, but basically just kind of hearing that, you know, African Americans just don't have oftentimes the same symptoms. So can you speak to the symptoms a little bit?
I think as far as the sensitivity of the symptoms, I think the fever is probably one of the biggest things to go by. Cough and shortness of breath. I think that I saw one study where up to 70% of people who had COVID kind of had those big three symptoms. The loss of taste and smell, I think, is a little less sensitive. But I think fever, cough, shortness of breath across all races are sort of the hallmark kind of symptoms to make someone think, okay, I may need to be tested for the disease.
Okay, so we can kind of stick with the tried and true. If you have a fever and the dry cough and the shortness of breath, seek help immediately would be your advice?
Yes,
or
you would definitely qualify to be tested. Another thing that's sort of interesting about that conundrum is you would have to actually go around other people to be tested. So although we're supposed to be, you know, social distancing and such, if you go to be tested, it's very likely that if you don't have it, you might go into the presence of people that do have it. So it's kind of a tricky thing where you could potentially have it, and if you feel well enough that you could kind of manage your symptoms at home, it's probably best to not seek immediate help and try to be around people. But by all means, if you have the shortness of breath, that's sort of the thing that you seek medical help for.
Okay, well, that's good to know. So what exactly, I guess, is the fever that we should be concerned about, like how high?
Well, fever by definition is greater than 101.4.
Okay.
Right, Boo? 100.4, 100.4. Okay.
100.4.
What was it, Boo?
100.4.
100.4. Okay. So when something's lower than that, we tend to call like a low-grade fever. But by definition, anything that's greater than 100.4 is a fever, and it's more concerning than if you get a 99.9 on a random day or so.
Okay. And I think we do have a raised hand or a question here. And also, I just want to say real quick, I think he might have said, what, Boo? Boo is Dr. Eureka Phillip-Dixon, who is Dr. Andre Dixon's wife, and she's also with us, and we're so grateful to have you, Dr. Dixon. All right. Go ahead, Kathy. Okay, looks like we have a question. So can we unmute? Looks like Llewellyn, you have a question?
Lou, can you unmute yourself?
Yeah, I want to ask a question about the antibody testing. What's the difference between antibody testing and the other tests?
So that is a good question. So the antibody test would be a blood test where they draw and check your body for the serum that has the antibody. The traditional test is a nasopharyngeal swab. I, as well as my wife, we've actually been tested, and it's a very unpleasant test. You can imagine this pen being sucked down your nose all the way to the back of your brain. That's essentially how they do the other test. So the antibody test is where they test, they draw blood in tests, versus the other one is a nasopharyngeal swab.
Okay. So that clears that up, because I think I was wondering that too.
Don,
So
you also have a question in the chat window.
Yes. So that question says, are there any cases of COVID-19 in people where no point of origin could be determined?
So another good question. So because we don't have adequate contact tracing right now, I think it's unlikely, because we know how the virus is spread. So if someone has it, it's very likely that they came across someone that probably didn't even know they had it. So because we know how it's transmitted, I think it's safe to say that everyone who gets it did come in contact with someone. It's just very possible that maybe that person had it and was asymptomatic when they passed it on to someone else.
Mm-hmm. And how can you be running around with something as vicious as COVID-19 and not have any symptoms?
So we know that it affects some more than others. We know that our populations that are most susceptible to have severe symptoms, and those people that have pre-existing conditions. We have our very elderly folks, as well as our people that have other healthcare disparities. For people that are younger and healthier, it might just sort of seem like a cold or an upper respiratory infection, but for people who are more vulnerable, they could potentially have more severe symptoms.
Wow. All right, so we do have another question, and someone said, I guess along those lines, why are the nursing homes so affected?
Sorry, I didn't catch that.
They said, why are the nursing homes so affected? Why is this really hitting the nursing homes harder than kind of anywhere else, if we believe what we hear on the news?
Sure. So the nursing homes, these are probably your most vulnerable people of them all, just because we know that as we age, we tend to kind of have multiple comorbidities, whether it's heart failure, diabetes, high blood pressure, cancer. So their immune systems have been weakened by a number of things, probably over a long period of time. And so when they were allowing people to visit nursing homes, when you visit your loved ones in nursing homes, it's possible that the virus is transmitted in nursing homes from that way.
Wow. Okay. All right, so I will move on to the next question. Someone said earlier it was stated that kids were more immune to COVID. In New York and around the country, today there are a large number of kids diagnosed with COVID-related illnesses, and some had expired. Should our kids and grandkids get tested? And then there's also something about an inflammatory disease that's impacting the kids more so that contract COVID.
Eureka, do you want to take this?
Tested?
I'll take it. So yeah, there is a multi-system inflammatory syndrome that's now being found to be related to COVID. Before, it wasn't that kids weren't immune, it's more that they weren't as badly affected, and a lot of them were asymptomatic. But it's basically their immune system just kind of going crazy and causing like inflammation all around their bodies. But whether or not they should be tested, like just like Andre said, you may bring these kids into contact with people who are truly infected, or if they are infected, they infect other people. So I don't think you should bring your kids to be tested unless they're really sick.
So do children have similar symptoms?
Yeah.
Or is there anything parents should really look out for?
Yeah, kids tend to show the same symptoms, fever, cough, shortness of breath. Now they're seeing some different types of rashes with the kids too. Same loss of smell, taste. They have similar symptoms. Some of them are usually mild, but the inflammatory syndrome, you probably would have like a more widespread infection where they actually look a lot sicker than like a typical cold.
What about those rashes? I think I've heard they talk about the show up on the kids with COVID.
Yeah, the rash is not specific really. It can look like anything. It's just like red raised lesions. I've seen some people have something called COVID toes, where the toes just get really red at the tips. But yeah, we're just finding out more information about it, so it's not like a specific rash that you can say, oh, this is COVID. You would definitely have to do testing for it. And I think a lot of the kids too, they have this inflammatory syndrome like after they even have recovered from COVID is what they found. They're finding more of the antibodies in their blood rather than them being positive for the PCR at that time. So the antibodies can tell you either whether it's a new infection or if it was an old infection that they had. And I think a lot of them, they're finding that it was a past infection, not like an active one.
Okay, thank you. And since you are with us, Dr. Phillip-Dixon, can you introduce yourself briefly for us?
Yeah, so my name's Eureka Phillip-Dixon. I am a pediatric resident at Cincinnati Children's Hospital in Cincinnati.
Okay, thank you. So you're definitely the resident expert on what's going on with the kids. Thank you. Okay, we have another question in the chat, and if anyone has joined late, you can put your question in the chat or you can raise your hand. So the question we have in the chat now, it says, is our current testing rate indicative of the rate of infection?
I would say no, just because know that we have people that probably had the disease that were not actually tested. So not everyone, because we don't have widespread access to testing, we know that not everyone's going to get a test. And so it's impossible at this point to determine our rate of infection, how many people are actually infected, which is why we have our social distancing measures in place. That's the only defense that we really have to limit the rate of infection, because we can't identify everybody that is currently infected.
Okay. So should we be concerned, like for a weekend, like this is a holiday weekend, and maybe, you know, we're hearing that maybe we can get together if we're outside, but then what if a strong wind blows and it blows somebody's droplets right into my face? Be concerned?
So, you know what? That's a good question, because everyone's been saying 6 feet, 6 feet, 6 feet. But yes, it's very possible on a windy day that 6 feet distance might not be adequate enough. The hope is that anyone who is around other people, if you do even so much as have a remote cough, that you would cover your mouth and that adequate hand washing would take place. And masks, if you have them, you know, you can take them off if you're doing a barbecue or something just to eat. But that's sort of the only defense that we really have, is kind of making sure that we keep our hands clean, that we our droplets, if we could potentially have any that we're spreading.
So I'm glad that you said that, because the next question was homemade mask versus medical grade mask. What's the recommendation, and are you okay with the homemade mask, the cloth mask?
So it's a good question, because masks are not readily available at the rate that we need them to be able to protect everyone. So everyone has different materials that they're using as their only defense, and for a lot of people that's all they can do. It might not be medical grade to be able to protect against 100% of the droplets that you may come across, but I think any defense is better than no defense. So if you have material that would potentially limit the transmission of droplets and you make your own mask, I think that's the best you can do.
Okay, thank you. All right, we have a question. I think, Pat, looks like you're trying to raise your hand. I meant online, but we'll take your question. There's a question right now in the chat that says, if you get the COVID and get treated, can you get it again? I love he called it the COVID. If you get it, can you get it again, basically?
So that's a good question, because antibody testing exists, but we don't know if these antibodies mean that, yes, you've been exposed to it. Right now, we're still doing research to find out if these antibodies protect you from a future infection. So to be determined. That's our hope. Our hope would be that if someone gets this, that they're protected from getting it again because it's so severe, and which would kind of create some sort of herd immunity where the people who have been affected by it don't have a way of contracting it or spreading it again. So that's what we're hoping for, but right now we still don't know.
Okay, so right now, if you have gotten it and you recovered, don't just think you can run around, you know, willy-nilly without a mask and stuff. You still have to be careful until there's a definitive.
Let's still be careful until until we know for sure that the antibody is protective. Then yes.
Okay, Pat, you're unmuted. We have we'll take your question, and then we also have two follow-up questions in the chat. Go ahead, Pat Butler.
Okay. You know, I don't know how true this is, but I heard this, and I'm hoping someone else has heard it. But they're saying that the flowers, the plants, can be affected with the virus. And I was wondering, they said that they haven't put it out there, but it's there. And I was wondering if any of the Dr. Dixons have heard of anything, or if anybody else know of anything like this, that you can get it from the plants. And I noticed that I don't see that much plants around, flowers. And I'm a big believer of planting. And if it's affecting the flowers, I don't want to go anywhere near it.
I hadn't heard that one.
I heard anything like this.
So yeah, I haven't heard about that either, but I will say that I think it's possible that if there are droplets on the flowers and you maybe smell them, I think that would probably be the only way to get it from the flowers. I think it's unlikely because we know that we know that UV light tends to kill the virus, and I'd imagine that if flowers are in the sun, that they probably aren't a surface that would contract a lot of droplets. But no, I have not heard that before now.
Okay.
Me either, but I guess to be safe, don't stick your nose in any roses. All right, so we have a question in the chat. It says, if it's recommended to stay home and self-treat if you're healthy enough, do you recommend getting the antibody test after the 14 days post-exposure has passed? And what is the benefit of getting the antibody test?
Sure. So I think when you're well and if a test is available to test for antibodies to determine if you had prior exposure to the disease, I think what that does more so in the long run is kind of help us with this data as far as did you have the disease in fact, and did your immune system mount an antibody that can be tested for? And then we can sort of, the more data we have from that patient population, we can kind of extrapolate and determine if in the future this antibody actually makes you protective. So I think it's more academic and educational to get the antibody testing after you get better, because it'll kind of tell us for sure, yes, you probably had it, and then going forward, are you protective against getting it in the future?
Okay, thank you. All right, so we have a question that says, this question is more about taking care of your mental health while dealing with COVID. Any tips or insight on that issue? Someone is quarantined in Bermuda and has been for 2 weeks, and it's really been quite overwhelming. So they want you to kind of give them some tips on how to manage your mental health while going through COVID.
Sure. This is probably going to be a tough one for me because I love being by myself. I love being an introvert. But for me personally, I try to find things that I like to do on a regular basis and see if I can implement that during the COVID shutdown. One thing I like to do is working out, and the gym has been closed. So I just sort of ramped up my running outdoors a lot just because, you know, I do enjoy exercise, and if the gym's closed, I can still walk, I can still run. So I would say trying to find ways to incorporate the things that you liked to do before the pandemic. If you liked eating at restaurants, maybe you can get takeout and sort of prepare a meal at home, kind of shape your apartment or your home like a restaurant and kind of make it an event. Whatever you like to do, I think trying to implement it as best you can to kind of help with your mental health is probably the best way to go.
For sure. If anybody else has any tips, feel free to share on the mental health.
I think Taraji P. Henson created a foundation to help with mental health, especially in the Black communities. I just can't remember the name. I'm trying to find it.
Oh, yeah, I heard about that too, Dr. Phillip-Dixon. That's a good one for sure also. So while Dr. Phillip-Dixon is looking for that link for Taraji's page, we'll look at another one of the questions. Lavin, you had another follow-up question, looks like.
And Don, Ayanna Van Zandt has also a program for those who are struggling with mental health during this COVID. Ayanna Van Zandt on OWN Network.
Okay,
Ayanna, yeah.
Yes.
Yes. So there's two resources, you guys. There's Ayanna Van Zandt, and then there's also Taraji P. Henson, both African-American females that have a particular interest in our mental health and well-being. So they've got some resources available online, so please check those out. I know that I have heard that they've put quite a bit of work into making those resources available.
Yes,
So,
and I think if you definitely want to speak to someone, I know that a lot of mental health professionals are still carrying like telehealth sessions, like video conference sessions, sort of like this sort of interaction. They're still doing that. Your mental health professionals. So if you do feel the need to speak to someone directly, you can find out who's offering telehealth services.
Yeah,
I think a lot of companies are also doing it for free for the first couple of sessions. So people who need it can come in if you don't have insurance or stuff. I think a lot of these community agencies are doing it for free for the first 3 sessions, and then, you know, so check it out.
Yeah, for sure. So we'll make sure we share some of those resources as well. Okay, Llewellyn, you want to ask your question, and then next after Llewellyn is Sister Delores West.
Yes, my question is, I have a family member who lives in the UK, you know, my niece, my granddaughter really, and she wants to travel, and I think that is not a wise thing to travel right now because the flight from England to America is like 7 hours. What do you think about that?
Okay, so travel's an interesting one because there are a lot of restrictions. I know that a lot of countries are limiting some travel through international borders. I would say that the same precautions, you just have to exercise the same precautions. If she is insisting that she definitely wants to travel, you know, the same rules apply. She would definitely ideally wear a mask through all the airport terminals that she would come across, making sure she washes her hands after she touches any surfaces. The airports have been doing a good job of kind of keeping surfaces clean, but of course, making sure she's washing and hand sanitizing as well. And then what we've been doing, we've been flying is when you sit down in the airplane seat, kind of make sure you wipe down all the surfaces in the airplane as well. So there are precautions you can take if you absolutely must travel, although the recommendation is to limit non-essential travel. But if you do have to travel, you can kind of take those same precautions.
Yeah, sounds like the recommendation is that she shouldn't if she doesn't have to, but if she just must, then yes, those are some great tips. Thank you. Okay, Sister
Sorry
West.
to interject, but I think there was a doctor who actually traveled. He's on a Good Morning America, one of those places, who put the gloves on, wiped down the seat, did everything, still got COVID. Now, he's not sure where he got it, but he thinks while he was traveling on the plane, the only place that was uncovered was his eyes. And he was wondering it, and he was saying that he thinks that that's where he got it from, that it's something, maybe somebody sneezed and it went into his eyes. So I don't know, because he said he didn't have on the goggles, he had no eye protection, but he had the mask, the gloves, and he still got COVID.
My goodness. So yeah, sounds like you should definitely avoid that travel if you can. So, all right. So, Sister West, did you have a question?
Yes, I do have a question. I participate in swabbing people for the virus at work. My question is, a lot of times when the participant sees the swab, they're very nervous and they're backing up, and it's difficult to get a good swab done. My question is, when you can't get a good nasopharyngeal swab, is the swab that you do get, which really doesn't go back far enough, is that ineffective, or is that just not enough to actually do a good test? Also, some people do not want you to go in their nair for the swab, and they want you to do an oral swab. But a lot of times these people have very severe gag reflex. So you put the swab in, and they're gagging prior to you even being able to get a sample. Will that, when you do stuff like that, does that negate the swab? Does it negate the fact that you don't have enough, or that the swab is ineffective? What you've gotten is ineffective in order to do the test properly?
Yep. So good question. So we know that the nasopharyngeal swab, if you go back in the nose and the person doesn't allow you to do the full tests, that you can get a false negative. So when I got my test in particular, it was very unpleasant. Let me just say that. But my kind of motivation for sort of sticking it out was I want to know for sure with 100% certainty that I have it or I don't, because I don't want to infect someone else. So I wanted to know for sure. So I think when we're testing these people, maybe we can kind of use that as a motivation to kind of get them to allow for the unpleasantness of the test to kind of take its course, knowing that we want to make sure we get a 100% accurate sample. We don't want to have to do this again, because yes, if we don't get enough of a sample, we could get a false negative and they could potentially still infect their loved ones. So maybe we can kind of use that as motivation to allow them to sort of tough it out.
Okay. So what about the oral swab?
I don't believe that the oral pharyngeal is more accurate than the nasal pharyngeal. We know that the nasal pharyngeal is the most sensitive way, I think, to test for the virus.
Yeah. Okay.
Okay. And Sister West is a nurse, and so that sounded like he answered your question well, and gave you some tips which you can tell your patients. Listen, if you want a good result, you need to bear with it. Dr. Dixon put it more nicely, but yeah, that was a good.
Yes.
All right. So Dr. Phillip-Dixon put the tips in. I'm sorry, the link in the chat for everyone for the mental health assistance, you guys. So if you want to look in the chat, again, under Dr. Phillip-Dixon, there's a link there for the mental health assistance. Okay, so we have another question. If it takes 1 to 14 days to see symptoms, how long does it take to actually recover? And what if you don't see any symptoms until that last day on day 14? Then you have to go another 2 weeks. And also, can you still pass the virus along after you've recovered? So I know that was a lot there, but
yeah. So I think there's studies that
read that one, Dr. Dixon.
Yeah, let's try that. You're breaking up a little bit too, so let me see if I can write each one.
Okay. All right. So they asked, let me go back to it. If it takes 1 to 14 days to see symptoms, how long does it take to actually recover? What if you don't see any symptoms, say, till day 14? Do you need to quarantine for another 2 weeks? And can you pass the virus along after you've recovered?
Okay. All right. So I think there have been some studies that showed that you could be asymptomatic for up to a week after contracting the virus. And it's believed that the course of the virus itself symptomatically is about that 14 days that we mentioned. So really, I think you're looking at a 21-day time frame between kind of contracting the virus and sort of recovering from the virus. It's difficult to say whether or not you can still pass it on, because the period that you took to see symptoms, it's possible that you've passed it on to close contacts in that time before you even showed any symptoms. So I think you're probably still infectious for a few days after you complete your symptoms. In the hospital, for the patients that get admitted with COVID, they're essentially, after the 14 days, they're retesting them. And some people are still testing positive even after the symptoms have subsided. So it takes a while for your body to actually clear the infection to the point that you test negative for the virus. So it's you could still, after you have your symptoms, you could still have the presence of the virus in your nasopharyngeal area, and you could still pass it on until that test turns negative.
Okay, thank you. Does warm weather help slow down this virus? Does it get more fragile with humidity? Can we be more hopeful now that it's gonna get hot?
That's what we're all hoping. That's what we're all hoping. We know that these respiratory viruses that spread via droplet, whether it's the cold, the flu, or now COVID-19, it's believed that the presence of UV light slows the rate of transmission. So right now, here in Texas, it's almost 90 degrees. So any virus that exists on surfaces outside is believed to probably die within a day on the surface outside in the sun. So in Texas, it's like free range here. You know, people are on the beaches that are on the Gulf Coast because we're hoping that with the presence of UV light and it being warmer, that the rate of transmission, at least on the surfaces of items and hard surfaces, that it's going to die on these surfaces, so that if you touch a surface that had the virus, but it's been in the sun for 2 days, and then you put your hands to your face, you won't get it that way, but you could still potentially get it from close contact. So that's why we're still social distancing.
Okay, well, we'll keep hope alive then. So now, in your opinion, doctors, how can we best support our medical workers through this whole thing?
So I think the best thing that we can do is kind of take our own precautions. By all means, continue to wash your hands, do your mask if you can. And in particular, when you're around someone that we call our most vulnerable folks, our elderly folks, or our patients with pre-existing conditions, limit your contact with these people, because we know that they're the people that are going to struggle the most if they get the virus. So while you might be feeling fine, kind of think about the more vulnerable in your day-to-day interactions, so that they don't end up becoming infected with the virus.
Okay, thank you. And can you all take a moment and tell us how this whole thing has impacted you as a healthcare provider?
For me personally, because I work now with cancer patients with cancer and blood disorders, in which they fall under the kind of more vulnerable pre-existing condition patients. So we've been doing a lot of our visits via telehealth. Of course, if someone has to come in for chemotherapy, you can't really do that over the phone or camera. But there are other office visits we've kind of made telehealth, just to kind of minimize their exposure to others. When they do come for treatment, either blood transfusions, chemotherapy, etc., everyone who comes through the hospital now gets a mask. So we're kind of limiting the closeness of our cancer patients, and while they're in the infusion center as well. So we know that we can't stop all operations, but we have implemented some precautions to kind of limit everyone's exposure, including ours. We've been working on a week-on, week-off schedule for most of March and April. So we're just actually getting back to our regular schedule now. But for a while, we would just have half of our team in for a week at a time, just to kind of make sure that everyone doesn't get exposed to the hospital all at once.
Dr. Phillip-Dixon, how about you? How has this really impacted you as a healthcare provider? And also, we have Dr. Dixon's aunt on the line. She's a nurse as well. Feel free to answer. other healthcare professionals, any comments about how this has affected you?
So I'm at a children's hospital, so we weren't hit as hard. So what we tried to do was limit elective procedures for children, just in case there was a big surge over here in Ohio. So we didn't have as many kids in the hospital, and then we would try to take like older kids or young adults from the other hospitals to limit the amount of patients that they had. So we started taking care of people who are a little bit older than we're used to. As Andre said, we also have like universal screening and masking for everyone coming in the hospital. And then as providers, they're trying to limit the amount of time that we spend here. Last month, I would spend maybe a week on and off in the hospital just to rotate. And I actually got sick, and that's why I was tested. So like any cold, any sniffle, they take it very seriously. So you will be swabbed, even against your will. But now that I'm in the ICU, I'm actually in the hospital a bit more frequently, just because of the high acuity of patients that we're dealing with. The ICU volume hasn't changed that much. It's only changed for the fact that we don't have our post-op kids who are elective. We actually have really, really sick kids actually right now. And yeah, it just makes me more cognizant of like where I'm going and who am I getting in contact with, so I don't pass on the virus. Well, if I do get it and I'm asymptomatic, I just don't want to pass it on to like the vulnerable population that I am dealing with. So I'm a lot more careful in how I conduct myself and clean my hands and interact with other people.
Yep. Well, we have a couple more questions, and then we'll be reaching the end of our hour. Is there anything you all can share, kind of positive, because sometimes we get overwhelmed with all the, death rates and all this stuff. Is there anything positive you can share? Maybe treatments on the horizon or any other light at the end of this tunnel you could share?
Sure. Again, we're all hoping that the warm weather, it will sort of slow the rate of transmission. We're hopeful that there's going to be a vaccine on the horizon. I was told initially maybe a year, but I'm hearing we could potentially have something before the end of 2020, which would be timely because with the fall, there's expected to be another rise in the number of cases, as well as coinciding with the onset of flu season. So the hope in a vaccine and that the summer months will decrease the rate of transmission. And then, of course, there's a new antiviral that's been shown to slow the progression of the virus. So I think that's promising, and we'll kind of see what data comes from its usage.
And then someone asked, which is also really, I guess, popular concern out here, what about another wave? We keep hearing about another wave. Is there anything we could do to prevent that? Or what are your thoughts on another wave coming through?
So, not to get too political, but I think it's going to be hard to slow another wave if we kind of start to loosen our restrictions, which is what's happening now. Again, we're hopeful that the summer months will decrease the rate of transmission. But I think without continuing our restrictions and people not continuing with their social distancing, we know that the virus will likely continue to spread. But again, you're sort of balancing that risk versus the risk of, everything that's going on politically and economically. So we can only, as individuals, kind of take our own precautions. Just because everything's open and back up, you can still stay at home. That's perfectly fine. You can still protect yourself, because you can only control certain things. There's things going on outside of us that could potentially lead to a second wave, but we could just take our own precautions.
So I want to Thank you. And I want to go back to this vaccine. Do you recommend it? Because I hear a lot of people saying, I don't care if they do come out with this vaccine, I ain't getting it. Then from a spiritual standpoint, some people are saying that has some relevancy there where, you know, we should all be rejecting this vaccine. What are your thoughts?
So I'm gonna be the first one to get it when it comes out.
Okay.
I mean, I think we might, like, just like how the flu vaccine is, where we have enough people that get it that if you choose not to get it, you're probably okay. We still recommend everyone gets the flu vaccine, but if enough people get it and don't get the flu, it's possible for you to avoid people that do have the flu enough for you to not get the virus, if that makes sense. But I think, you know, we know that over the course of 1,000 years of medicine, that vaccines are the only way to get rid of a disease permanently. That's just how we got rid of polio and mumps and rubella and all these things that we have vaccines for. This is the way they were eradicated. Flu vaccine, we're still trying to convince people to do every year, but we know that it's effective in people not getting the flu and kind of limiting the rate of transmission. So I'm pro-vaccine, but again, if you are anti-vaccine, you could still potentially not get COVID and not get the vaccine by just kind of staying away from people.
Okay.
Since we're talking about vaccines, I got a pediatrician plug. We've had a lot of kids who probably are not coming in to get their usual vaccines. So in addition to COVID, they're also at risk for other things like measles, mumps, rubella, tetanus, all those things. So kids should still be getting their vaccines in this season. There's actually like a fear that there may be a measles outbreak coming soon. And measles can be pretty devastating. It's not just a rash.
Yes, that's true. All right, so I don't think I see any other questions. So any final words on what you just wish everyone would do or remember during this trying time?
Sure. One thing I would want to express is, you know, these are tough times. However, these are not unprecedented times. We know that we went through we've gone through swine flu pandemics and avian flu pandemics. There was SARS, there was MERS. And so because of those prior triumphs in which the Lord has showed up and kind of delivered us through these times in the past, we know that we'll get through this together as well. Please just try to turn off your CNNs and your national news stations and kind of focus on what's going on locally. Take the precautions that you can, and just know that God will prevail, and you just take care of yourself and your family.
Okay, thank you. Any final words, Dr. Phillip-Dixon?
I concur.
Okay.
Well, thank
All right.
you.
Oh,
Thank you for this. You have one more hand up for Llewellyn.
You got to unmute yourself.
Hello? Yeah, I want to ask a question about the herd immunity.
Mm-hmm.
Yeah, is that a good idea? Because some countries are not practicing social distance at all. They haven't closed down nothing, like Sweden and countries like that.
Yeah. So herd immunity, when we talk about herd immunity, essentially we can defeat this virus either by enough people mounting the antibody that is hopefully protective and decreasing the amount of people that it spreads to, or if enough of vaccine becomes available, or maybe enough people get vaccinated to the point where this disease in the future could potentially be something that we don't see anymore. And that's how we kind of classify herd immunity, is that the virus essentially has nobody to spread to because everyone either has been vaccinated or has an antibody to it. And so we can see it kind of taper off that way. In other countries where they're not social distancing and they're not seeing spikes any longer, then it's possible that maybe this antibody is present there, and it's enough people have either gotten the virus in a mild form and recovered, or there's essentially no way for it to spread to other people. So that's another thing to be optimistic about, is that this antibody will be protective, people will get vaccines, and then essentially the virus has nowhere else to go and will kind of die out.
Yeah. Okay, well, we have one more question, and then we're going to ask our first elder to please pray for us as we conclude, of course, for blessings for our healthcare workers as well as the members of our church family. Okay, the last question comes in, and it says, what about the TRACE Act, which will require all humans to get a vaccine? Have you heard anything about that? I know I haven't. A TRACE Act.
I think it's something that I might have scrolled past on social media. Give me time. I can look into it and find out more, but I have not heard about it being mandatory vaccination policy as of right now.
Okay. All right, and again, everybody, if you want to just take a second and look in the chat, if you need those resources that several members have posted, I thank you. Where, for mental health, Dr. Phillip-Dixon posted one, Dr. Kathy Holmes posted one, and Kathy also posted one where we could just call 211md.org if you need help. Okay, so we've got about 2 minutes left. So we want to again thank the doctors. Dr. Dixon, we really, really appreciate you taking time out to join us. And if I just may say, we are so very proud of you. We're so proud of you. And just know that we're always praying for you and thinking of you. And, that God will protect both you and your wife.
Amen.
Continue to move on in your career.
Thank you
All
so
right.
much.
Good seeing you, man.
Okay. So
Amen.
let's, yes.
We'll close.
We're just so proud.
Yes, indeed.
Dr. Dre.
So before we close, I just want to again give everybody an opportunity to use the chat window, give some shout outs of encouragement. We want to again thank our host, Elder Don Simmons, for coordinating and pulling this together. We thank you, Dr. Andre Dixon, and your wife, Eureka Phillip-Dixon, for accepting the invitation to have this interactive health presentation. And again, we want to thank our church family for coming out in strong numbers to support. So at this time, as we're closing out, we just want to have a word of prayer. Heavenly Father, we thank you for all of our healthcare professionals who give of their time and their talents every day, putting their lives on the line. We thank you so much for giving them the skills and the talent and the wisdom and how to care for us as a church, as a community, as a country. And we just ask that you will bless around the world all of the healthcare professionals that work day in and day out tirelessly to be on those front lines and make a difference in this time of crisis. We thank you for the wisdom, the words of instruction and guidance, and we ask, Lord, that you will bless us all to have peace of mind, trusting in you, to give us wisdom in how to conduct ourselves, to protect our families and those who we come in contact with. We especially pray that you will help us, by your grace, to continue to do all that we can to make a difference in others' lives. In Jesus' name we do pray, amen.
Amen.
And Sister Louise, we want to thank you